And maybe in about 15 minutes let me know where I'm at. I'm cursing the Women's Council. It's on. I'm cursing you, Rachel, and the Women's Council. Can you hear me now? Because you put me at the end, and particularly after those four women, very powerful women's speeches. You see, I moved my hand. It's a problem we've got here. Anyway, I'll try and keep it here. And there's a phrase I think in Northern Ireland which is "folly that," and I think I have a very hard act to follow. They also sort of gave me Mission Impossible, which was to talk about women's health status, inequalities in women's health status, inequalities in access to the health services for women, and the impact of the 5 austerity budgets on women in 15 or 20 minutes. Okay, so I'm going to do a quick whistle-stop tour of the main aspects of the programme for government in relation to health, a critique of progress to date, and then finishing off around the impact of the austerity budgets on women's health. And I'm not going to go into detail on women's health status. A lot of you will be familiar with the statistics. Jane referred to some of them in her input. There is a very recent publication from the CSO which is coming out of the census data, so it's really powerful information we now have. And it very clearly shows that women are living longer, that there is more disability among women, and that 70% of those who live alone over 65 with a condition that limits their basic physical activity are women. Contrary to your figure, Kathleen, it says 66% of carers are women. There's poorer mental health among women. The physical health story is a slightly more complicated story, but with women experiencing poorer health than men later in life. And of course, there's higher poverty among women. And I just flag those up to you because I'm giving a general critique of the health service and of the budget, but because women are more dependent, because they live longer, because they give birth, then cuts are impacts upon the health services hit harder on women. The programme for government, it actually is worth revisiting it to see what the Labour Fine Gael government promised us. And actually, the health components of the programme for government are quite radical. It's the first government in the history of the state to promise universal access to healthcare based on need, not ability to pay. They're proposing to do it through this model of universal health insurance. We actually don't have the detail of the model, and I would argue that if they used the evidence base that's there, then they wouldn't go with the competing private providers model that they're currently proposing. But they did in the programme for government commit to do it on the basis of social solidarity, about ending discrimination between patients dependent on income or insurance status, about ending the 2-tier hospital system of care. Kathleen, I think you said that if you're wealthy and if you've money, you get better access to healthcare, and you're dead right. Not only do you get, fundamentally you get quicker access to healthcare in this country if you're richer or wealthier. The government also, with this plan for sort of universal access, committed to bringing down the costs of care. The Minister has established this special delivery unit, which people refer to as his SWAT team in the Department of Health, to drive down waiting times, and I'll come back to that. He's also promised greater responsibility in relation to health policy and cost control. He sort of bragged about abolishing the HSE and it ceasing to exist over time, and bringing many of those functions back into the Department of Health. A key stepping stone to their universal health insurance proposals is free GP care for all by 2015, making hospitals into independent trusts, and Jane did a very good critique of that for Impact Trade Union. They're going to spend money by money following the patient. They commit, and I think it's important to flag this in light of the cutbacks that we're experiencing, more and better care for older people. They wanted to bring down the price of drugs, invest in capital infrastructure, so that's buildings and equipment, which are very important in healthcare. New contracts for doctors, cutting their pay, a range of mental health commitments, primarily about implementing a vision for change, which has never been implemented, and particularly focusing on community mental health teams. And then, interestingly, there is a section around bioethics, and they talk about legislating to clarify law on assisted human reproduction, regulating stem cell post-mortems, organ retention and organ donation. And then I just put up the wording of what they say in relation to the X case, because they don't commit to legislate for it. And it's really the last sentence here, with a view to making recommendations to government and how this matter should be properly addressed. And certainly I still haven't resolved the conundrum about how you get legal clarity without legislating, but perhaps our political leaders will tell us the answer to that sooner rather than later. So, how are they faring? I think we still have to give them credit for the fact that they are planning to introduce a one-tier health system where access is based on need, not ability to pay. I think the plans for free GP care are very welcome. There has been some progress on hospital waiting times, and I'll talk about that in a minute. And I think there is this renewed emphasis on public health and primary care, which much hackneyed and we'd heard a lot about, but they're flagging it again. We need to try and hold them to that. In terms of implementation and how far they've got, in my opinion, they haven't got very far at all. And crucially, they haven't told us how we're going to get from the complicated, unfair, messy system that we have to the system that they want to get. It's a huge reform process, and in order to get there successfully, they need to map out the pathways and the roadways. And I think it was one of the really significant bones of contention between Roisin Shortall and James Riley was he kept on changing his mind or saying different things, and she wanted to pin him down, going, how exactly are we going to get from where we are to where we want to be? And as a result of that, they had a lot of difficulty or disagreements about producing this roadmap. And then they published this roadmap about a month ago. And it's definitely not a roadmap, and it would be very interesting to have known what it might have looked like if Roisin Shortall was still in the Department of Health. It's 50 pages, it's appallingly written, it's difficult to read, there's little new information on it, and if anything, it's a retrenchment of previous commitments within the government, the programme for government. I just word searched both the programme for government and the future health document this morning, and for women. And I think there's 8 mentions of women in the programme for government, mostly around political reform and better representation, which obviously would be very welcome. And I think there were 6 references in the future health document to women, and only 1 commitment, which is a previous commitment made about extending breast check to older women. And I think the invisibility of women in both the programme for government and in the future health document they're notable in their absence rather than us being part of it. So I'm going to, how am I doing for time? I'm going to run through these and then do a sort of brief analysis of the budget. How far am I in? 10 minutes, okay, that's fine. Halfway. Progress on free GP care. I think one of the things we can really judge this government on, of whether it's delivering its health commitments or not, is whether it delivers on GP care. We also heard, and I guess we wouldn't have heard it if Roisin Shortall hadn't resigned, that she was ready to go with 300 additional primary care staff. There had been about 15 months of analysis done about what are the communities that most need speech and language therapists, additional nurse specialists, speech and language therapists, and there's vast communities around the country without access to these at all, or with very, very long waiting lists. So in order to have better better primary care, we have to have these professionals. And the night before she was due to announce it, she was told by James Riley's advisor she wasn't allowed to do it because perhaps they were looking at alternate options of delivering these through privately hired by GPs. So I think their failure to deliver on, there was a ring-fence budget for this, and Minister Riley has acknowledged at press briefings that the 35 million for these extra staff was basically used, and I think these were his words, to mop up the overspend on medical cards, because there's higher levels of unemployment, more people are entitled to medical cards. I also think that the steps to free GP care was that everyone currently on the long-term illness scheme would have had free GP care by last March, and everyone currently on the high-tech drugs scheme, and these people by their very nature are the sickest people, would have it by next March, and they obviously have failed spectacularly to deliver the last March deadline. Alex White, the new minister with responsibility for primary care, is saying that the legislation is very complicated, that they are going to issue GP-only cards, which in effect is free GP care to people on certain illnesses. We haven't even seen a draft of the legislation, so I think the chances of that being through by this March are very, very slim. And I also think the debacle around primary care centres, and listening to you speak, and you laid out the sort of criteria for essential right to health, and I can guarantee you this government, the Irish government, breaks every single one of them, but particularly its absence of the use of evidence. And again, Roisin Shortall was very strong that the allocation of new primary care centres under the PPP schemes should be determined by deprivation and need in those communities. And we know from the Freedom of Information documents, reluctantly released eventually to the media, that James Riley parachuted in 2 primary care centres in his community, which was pure political interference, and they were, you know, number 122 and 59 on the list, like nowhere near the top 25 or 35. So I think their failure to deliver on their commitments on primary care is a significant black mark on their programme for government commitments. Similarly, around driving down costs, and I won't go into a lot of the detail on this, but a big part of driving down the costs is treating people in the community and not in the hospitals. If you don't have the staff in the community, then people will end up having to go to the hospitals. So those 300 staff make it more difficult to deliver care in the community. The home help hours we've heard a lot about in terms of the protests in August, when an additional 450,000 hours were to be cut between August and Christmas. We know that a key element of keeping people at home and in the community is providing home help hours, no matter what the government says. I think last week it said it was reinstating those home help hours. There are still, I think, going to be 2.5 million fewer hours, home help hours, this year than there was in 2008, despite the fact that we have a growing ageing population and we're trying to keep people out of hospitals and nursing homes and at home, where most people want to be. They've shelved the idea of cutting consultants' pay. I suspect they are just about to further cut GP pay. They haven't even begun to renegotiate either contracts. Spectacular failure to deliver on drug savings, and again we saw through the Freedom of Information request done by the Irish Times, political coziness, you could say it, at its nicest between the Taoiseach and heads of pharmaceutical companies. James Riley heralded this 400 million saving in the drugs budget with this new deal. In fact, if you look at the fine print, it also includes delivering new drugs. Those new drugs will cost 210 million. In fact, that makes it only 190 million savings. Recent WHO reports say we pay the most in all OECD countries for drugs. They were meant to save 125 million this year. They recently acknowledged they only saved 16 million. A big reason for the cutbacks now is their failure to deliver on cost savings in the drugs budget. And that is contributing, among other things, to why we had a deficit and then a much denied and then late announced supplementary budget. They need to speed up. You could say, if you think it's a good idea, that the Minister has been quite successful with his plans to abolish the HSE. He got rid of the board, and the board got rid of themselves before they were fired. He got rid of what, in my opinion, was a pretty competent CEO. He's introducing these new directorates, and they're listed for you there, and then Child and Family Support Agency is going to be a new separate agency in 2013. But there's no detail on how those different directorates are going to link, and most people don't just fit into one of these pillars. They're human beings with mental and physical health who might need social care, and we've none of the detail on that, and I suspect we've none of the detail on that because I suspect they don't have the detail on that. And then on top of that, they say, so this is an interim measure for 2 years, and then after 2015 it's all gone, and we've no idea what's in place after that. There has been some credit in the special delivery unit about driving down both wait times in emergency departments and for public patients for hospital treatment. The Minister says it again and again, 25% fewer trolleys in the first 10 months of this year. There were still 45,000 plus people waiting on trolleys. And interestingly, they've stopped measuring the time people wait on trolleys, which is very convenient. They have reduced the longest wait time between it's decided when you need a treatment and getting the treatment. And they have done that at every level. So there's fewer people. They've pretty much eliminated over 12 months. And there's significantly fewer over 3, 6 and 9 months. And that is a significant achievement in a health system with fewer staff and less money and a growing ageing population with a greater burden of disease. But there are still far too many people waiting. And it's only, again, Kathleen's point, it's only the public patients who wait this long. If you've private health insurance, you can be damn sure to get your treatment much better, much quicker. And also, it's these 385,000, this is where the real inequality exists in the Irish health system, because this is when you're referred by your GP into the system. To give them credit, they're collecting this information for the first time, but it's shocking that there are over 385,000 people waiting for that first appointment, and 11,000 of them are waiting over 4 years for that initial appointment with a specialist. And I would think that any of the progress that's been made has been delivered much more to do with the clinical care programmes that have been in place rather than Riley's SWAT team in the special delivery unit. He's pretty much had a purge on everybody around him, except, in my opinion, for the yes men he is surrounding them by, and they are men. And he's determined to bring the power and the purse back into the Department of Health, and most notably in the budget. And I think that's evident in the people who he has largely handpicked and put around him in the political interference in primary care centres. And in terms of this is going to be this huge reorganisation of the hospital groups, with this expert group advising him on what to do. And when I said what were the criteria you were using to decide these groups, and the press statement I got back was the government will decide the makeup of the hospital groups. Like, why bother commissioning an expert group to advise you on something if it's going to be a political decision? And I think part of the worrying, I know I'm really there, the worrying thing about bringing the power back into the department and being a minister who politically interferes means that you then can politically control how that 13 billion of health budget has been spent. Okay, budget, 3 minutes, I'll do the budget, okay, because it's grim, we'll get through it quickly. The budget announced last week is to take, basically to stand still, to provide the same amount of care to the current population in 2013, they've to make 781 million in savings, or take that out of the system. And that's on top of 2.5 billion and 9,000 fewer staff that have come out of the health system since the height of the boom in, I think, their comparative figures for January 2008. They're talking about getting 323 million of these savings from primary care, 160 million of these from drugs, which I spoke about already, I think is very unlikely. And I think perhaps the sort of the meanest measure, or the measure that has least evidence base behind it, is the increasing of the drug charges. This is one of my hobby horses that I've been banging on about for years when Mary Harney introduced the 50-cent charge for medical card holders. Labour and Fine Gael both campaigned for the last election saying they get rid of prescription charges. In this budget they trebled the prescription charges for people on medical cards, and they increased the drugs payment scheme from 132 to 144. The international evidence on this is black and white, that any charge, no matter how small, deters people from essential treatment. It's often things like diabetes management, asthma management, mental illness. So people feel okay, and they don't have the money in their pocket to pay for their drugs, and they stop taking them, and they end up as an acute admission into the hospital system. They make absolutely no sense. And also, people say, oh, 150, it's not an item. Actually, again, the international evidence is very clear on this, that the people this affects most is older women with mental health conditions, because if women live longer, they're more likely to have a variety of conditions and maybe 10 prescription items, so that can bring them up to the maximum of 1950 a month. And also, €144 out of a low income is a huge amount of money for any person or family to have to spend on essential drugs. They're going to cut the professional fees, which they need to do. We pay our professionals higher than any other OECD country. They're reducing down, but only very slightly, the eligibility for over 70s. So they're basically protecting richer over 70s. And then, and I described the press briefing at the health budget like, you know, that child's game if you put the tail on the donkey blindfolded, because they didn't give us any information. So the journalists were going, are you increasing emergency charges? Are you increasing the charges for the fair? We were guessing what the government was doing, and this was one of the ones we guessed. And they are going to tighten up eligibility, so they're going to make it harder for people on low income to get medical cards in 2013. They've increased the debt charges for nursing home support scheme, increased charges for public and private beds. They say there are no cuts to home health, but there's possibly, I don't believe that for a moment. And if there are no cuts, it's no cuts on this year's hours, which is 2.5 million fewer than 4 years ago. And they talk about, Kathleen Lynch talks about this new money for mental health, and I don't believe for a moment that that is new money, and I'd love to see where it's going. So, in conclusion, I'm there, Kathleen. You can't take that amount of money out of the system without impacting upon patient care. There's two explanations for giving us little detail. One is they don't know it, or two is they won't tell us. And I suspect they just don't know it. And I'm not sure which is more worrying. I think we're bound to see a retrenchment of services. It's inevitable in 2013. And that the increase in charges and reduced services hit hardest on the sickest and the poorest. And then the government gives us this mantra, well look, you can't just take one measure. Don't take those respite cuts. Look at the budget in its entirety. But if you look at the budget in its entirety, and these are just a few bits from through a woman's lens, there's cuts to child benefit, they're taxing maternity benefit, cuts to frontline services. Obviously maternity services have been in the spotlight since the death of Rita Halappanavar. But actually, if you look back over the years, Tanya McCabe, who died in childbirth in Our Lady of Lourdes, the report into her death said that constrained, huge demand in services and understaffing contributed to her death. A Nigerian woman, which was only written about in the migrant newspapers, Bimbo Onunaga, died in March 2011 in the Rotunda. The hospital report there said that the extreme activity level in the hospital contributed to her death. So the maternity service, if we just take one aspect of services, are seeing more and more women, because we're in the middle of a baby boom, using the public health system with fewer staff and less money to do it. We're going to see a tightening up of medical card eligibility, the cuts to respite care.